All right. So, again, I'm Dr. Sansevere from Boston Children's, and I'm going to be talking about newly diagnosed kids with epilepsy. And this is what I'm going to go through here. I think it's really important that when a kid is seen by either a neurologist or an epileptologist for a question of seizure, that it's really important for families to know exactly what we're thinking. So I'll go through that in a little bit of detail. And the other thing is, we see a lot of second opinions and sometimes third opinions. And, the main test we rely on is the EEG. And I oftentimes find that families really don't have a good understanding of what has been found on the EEG, what it means. So I'm going to try to focus a little bit on that. And then we'll briefly talk about the difference between generalized and focal seizures and why it's important to figure out which type you're dealing with. And then, as I said, we'll just sort of open it up to questions, and I'll answer any questions that anyone might have. And feel free to stop me at any point if you feel like you have a question or something's not clear. All right, so the first thing I'll go into is the actual definition of a seizure. This is kind of the technical definition, but I think that's okay. So a seizure is basically a clinical expression of abnormal, excessive synchronous activity of brain neurons, in the cortex. So the larger part of the brain. And then, kids can have a seizure, but then not necessarily have epilepsy. But the diagnosis of epilepsy is a little bit different. It's characterized by recurrent, two or more unprovoked seizures that are typically separated by more than 24 hours. Or you can have one seizure that's unprovoked, and there can be other tests that indicate you have a really high probability of another seizure. And in that case, you can be diagnosed with epilepsy after just having one seizure. So as I said, it's really important for everyone to be aware of what we're thinking as doctors. So the first thing that we always think about is, of course, was the event in question a seizure? Because believe it or not, there are a lot of mimics out there. Kids can pass out or have syncopal events that can look like a seizure. In some cases, stress, any form of stress, physical, as just one example, can bring out an event that looks like a seizure. And the way we sort of figure that out is just by the description of the event itself. We focus a lot on the state after a kid has a seizure. So I'm sure many of you have heard of this idea of the post-ictal state, where kids are extremely tired, hard to get them back to their normal baseline after an event. That's one thing that might help us to decide if an event was a seizure or not. But after we get a sense of the event from families or whoever witnessed the event, and we've decided that we need to be concerned, we try to ask ourselves, based on the event, what type of a seizure was it? So was it a generalized seizure in which both sides of the body were involved, or was it a focal seizure where perhaps one side of the body was involved, or kids had other symptoms such as just confusion or something along those lines? And then oftentimes, to help figure that out, we rely on the EEG, which is just that brainwave study. And then after we get the EEG, depending on what it shows, we start to ask ourselves, well, why did this happen? What was the cause? And there are many common causes for a kid to have a seizure and a kid to have epilepsy. One common cause is a brain abnormality. Many children have what we refer to as a cortical dysplasia. Some kids have had strokes at a very young age, and they go on to develop epilepsy. Another common cause, and one that we're learning more and more about literally every day, is our genetic causes. And I think one common misconception, genetic doesn't necessarily mean inherited. It is oftentimes the case where nobody in the family has seizures, and then we find an abnormal gene associated with seizures in a kid. And then, finally, unfortunately, even in the year 2020, there is still this group of seizures or group of kids that have seizures. We just don't know what the cause is. And we do speculate that even though we don't know the cause, it may still be something genetic. Um, and as I said, we're learning more and more about that. And then after we make the diagnosis and we have a sense of the cause, we ask ourselves, well, what is the best treatment? Typically, we focus first on medications, just because those are sort of the easiest things. Other options include things like the diet. In some forms of seizures and epilepsy, the ketogenic diet can be helpful. But there is also a subset of children that will benefit from a brain surgery. And keep in mind, there are many different types of brain surgery. Like most people think that the only type is the one where we actually take part of the brain out. Fortunately, there are other options such as things like a laser ablation, where we put a little laser into the brain and can burn out part of an abnormal area. There are other less invasive things like a vagal nerve stimulator. These are some other options that are lumped under this term of surgery. So then, just to give you a sense of that EEG, we focus on a couple of things in the EEG. The first thing we focus on is just the background brain waves, and they should literally look like waves. If you look at the right side of the screen here, that's exactly what normal brain waves look like. And these waves should be at a certain frequency based on the child's age. But then we also look for abnormal waves called spike waves, where they're very spiky, and then sharp waves, where they're a little bit sharper than the normal background brain waves. And then it's important for us to see exactly where those waves are coming from. Are we noticing that they're happening just on one side of the brain? Are we seeing these abnormal waves on both sides of the brain at the same time? These are important things that we look for when we do the EEG. And then just to give everybody a sense, we do like to capture seizures, but unfortunately that's not always realistic, because some kids have very frequent seizures, some have infrequent seizures. And all a seizure is on the EEG is when these abnormal waves build up very quickly and then sort of dissipate over time. And when that pattern happens on the EEG, that's when a kid will, have their clinical correlate, whether it be jerking or confusion or impaired awareness or whatever it might be. And then there are some common questions that I get. A lot of families ask me if spikes or sharp waves are seizures. The answer to that is no. A spike or a sharp wave just means that a kid is at risk of having a seizure. In some cases, it doesn't necessarily mean that a kid has ever had a seizure. There are certain abnormal background waves that can be seen in kids, and a subset of those kids never go on to develop seizures. Then another common question that I get is do these spikes need to go away for seizures to be controlled? And the answer to that is no as well. We have a lot of kids who are very well controlled on medications that continue to have spikes on their EEGs. So as I said, when we say that there are spikes or sharp waves, it just means that there's risk of seizure. But sometimes finding those abnormalities can help us to decide what the cause of the seizures might be. And then with regards to medication or treatment, this goes back a little bit to this idea of does the type of seizure matter? And as I said, it does. Focal seizures tend to respond to certain types of medications. And then the reverse is true, where generalized seizures may respond to specific medications. And you have to be careful, because certain medications that might be good for focal seizures may actually make other types of seizures worse. So these are the reasons why really the focal versus generalized seizure matters. So those are the basics, and this is sort of the framework that I think it's important for everybody to be aware of. And keep in mind, when a child is first diagnosed with seizures and epilepsy, it's extremely overwhelming. The first thing is, to see your son or daughter or anyone in your family have a seizure is terrifying. But I find that it really takes time for people to really get a sense of what's happening. But these are some important principles for everybody to sort of be aware of when it comes to a situation in which we're trying to rule out seizures and epilepsy. All right. So as I said, I usually just like to start with a few slides and then kind of open it up to questions. So we're going to stop sharing the screen here if I can do that. And as I said, just what are some of the questions that are out there? Tell me some things that are on your mind. And we can look at some of these questions here too. Let's see here. All right, so to answer the question, I have a question here about the percentage of children that go without an unknown cause. And I will say that varies a little bit. My sense is that it's probably around 20, 25% these days as we learn more and more about genetic forms of epilepsy. That said, as I mentioned, when we're in a situation where there's no clear brain abnormality and kids continue to have seizures, it is really at that point where we start to think to ourselves, this is probably something genetic, even if we can't find a specific genetic abnormality. In the age of genetic studies, we're now doing whole exome sequencing, which has increased the yield of the genetic tests. So, my sense is probably about 20, 25% or so at this point still don't have a clear cause, maybe a little bit higher.
Hi, I have a question. My daughter's, thank you for doing this. My daughter's seizure, the only one that she's had, involved her vomiting while she was seizing. Is that common?
It can be common. It can happen in specific types of seizure disorders in childhood where vomiting is the manifestation of the seizure. So yeah, we do see that relatively frequently. In older kids, vomiting alone is a little bit unusual as a presentation for seizure, but in younger kids, we actually see that pretty often.
Okay.
So
thank you.
A little unusual, but the answer is yes.
Okay, she's 4. So.
Yep. So that makes a lot of sense then, and that's actually in young kids who have vomiting as their seizure presentation. Most of those kids tend to grow out of that type of epilepsy. So that's
we hope so.
Yeah.
Thank you so much.
Of course.
I have a million questions if nobody has. And these are questions I've talked to her neurologist about, but just we're very new to this.
Yeah.
Just little things I wonder that I didn't notice before her seizure, which was 2 months ago. It's just like darkness under the eyes. Her seizure was a nocturnal seizure. If I look at different support groups for parents, which is how I found out about this EXPO, but there's a lot of theories about like, yes, dark eyes are going to signal like seizure activity is coming. As a new parent in this, should I look at all of that stuff, or really just is that going to take me down a path of no return?
Well, that's a great question. I will say that does happen in many situations. But so for me, the question is, why does she have dark circles under her eyes? As you probably know, the biggest or one of the biggest triggers for seizure is lack of sleep. So if you're sort of associating that with days that she's not getting good rest, then that's something definitely to focus on, because that's sort of the one thing that we have some control over.
Yes.
And I say that and it sounds really easy. I recognize that it's not always easy to get young kids to go to sleep at a certain time, but so that's, if it's in that context, then I think it's worthwhile to look a bit further into. And, some questions to ask yourself are things like, when she wakes up, is she rested? Does she snore at night? Is she very restless at night? Things like that.
Okay.
That will help you get into that question of, is she just really tired on certain nights?
Okay. And then if nobody else jumps in, I have another question.
I have a question, but if you want to go first, Candace, go for it.
Okay, it's my last question. So just, being anxious and a new person to this, should I have rescue meds for her no matter what? Or is that really just depending on the type of seizures that she exhibits?
Yeah, so it depends on the type, but it also depends on just how families feel about it. Those are the things that I think about when I'm going to prescribe a rescue medication. Um, so I do tend to err on the side of caution and make sure families have something on hand, just in case, for some reason there's one seizure that goes on to be a little bit different or lasts a little bit longer than we might like. Um, so, unless so the answer from my standpoint is that for the most part, I do tend to prescribe some kind of rescue medication for families. The majority of families don't wind up using it, which is good, especially if I'm in situations where I think it's a benign form of seizure. But there are a lot of really good options out there now. 5, 10 years ago, it used to just be rectal diastat, which has a lot of challenges, right? Maybe not in a young kid, but now there are many other options. There are nasal options, which are a lot easier to use. There are some buccal options where you can put something in the cheek. So from that standpoint, I really don't feel like there's a downside to it. The problem is, you want to make sure that it's not being overused, right? Because when a kid has a seizure, it seems like it lasted 5, 10 minutes. And in reality, maybe it's lasted 10, 20, 30 seconds.
Right.
Just because it's almost like time kind of stands still when a kid is having a seizure, to be honest. And I've experienced that myself. So those are some things to be aware of. But for the most part, kids tolerate it, pretty well. The concern always is that it's going to interfere with breathing. And luckily, as long as it's dosed appropriately, we don't see that often. You know, so I err on the side of caution, and most of my families have some form of rescue medication. And again, keep in mind, luckily, we don't worry too much about seizures that are brief, but the seizures that are the big ones where kids get stiff and have jerking, if that lasts longer than 5 minutes, there's a chance it might last even longer. So,
Right.
you know,
Okay. Well, thank you so much. I appreciate it.
of course.
All right. My question is more around the genetic component of it. I know that you mentioned that likely, you're finding that there's more of a genetic correlation with epilepsy and children. And so my son was, like a lot of the others, recently diagnosed. We're not entirely certain what type of epilepsy. Initially, they were thinking possibly benign Rolandic, but his EEG isn't textbook for it. But so we did genetic testing, but the genetic testing is kind of inconclusive. There were a couple of markers, so we're going to do some follow-up testing. But because of that, our neurologist down here in San Diego doesn't think that it's correlated. But if you guys are thinking that there's more of a genetic component, could it just be that there's not enough research on, his specific variant on both of those markers? Or, I mean, we don't have a family history of epilepsy that we know of on either side, but, there's just so many questions. So we're just trying to understand a little bit more about it. And, genetic causation is definitely something that we're wondering.
Yeah, sure. So first thing I'll say is that so just because the EEG is in textbook for Rolandic epilepsy doesn't necessarily mean it's not still that. So that's the first thing. And again, it depends on exactly why it wasn't textbook. So that's the first thing. It's a little bit of an aside. But yeah, the sense is that, so number one, we've just recently started doing whole exome sequencing, and that's kind of like the fanciest genetic test out there, right? So that sort of ties in with your question, because we haven't routinely been doing that, I suspect that as more and more kids get that, we'll start to see more and more genes that are not being picked up on the other panels, right? So for me, the order of progression for the types of genetic tests that I order, and this varies a little bit, but there's a specific panel called just the Comprehensive Epilepsy Panel, and that looks at specific genes that we know a lot about. But oftentimes that's negative because, there's only so many genes that we know about, even though we know a lot about a lot for the most part. But then, I'll start with a wider test, like a chromosomal microarray that just sort of gives you a very broad overview of all of the genes. But I have been transitioning to do whole exome sequencing. And that looks at everything. It looks at the genes, it looks at the information between the genes. It's the most comprehensive test that we have out there. Now that said, we are in the situation where we find these variants and we don't really always know what to do with them because it's still a test that we've just started doing, and we haven't found many associations with certain genes. And I will say there have been situations where I get a result back and it's, oh, this is not pathologic, and then 4 or 6 months later I get a repeat, not a repeat test, but I get a second report that says, oh, we found 20 other kids with this exact abnormality. So my sense is that we're just, as you said, the research just isn't there yet. It's coming along pretty quickly, but because there's got to be some reason, right, for why these kids are having seizures, and as I said, it's at the end of the day, it's most likely something genetic after we've ruled out
right, normal MRIs.
Yeah,
obviously something is causing an abnormal EEG. If it's not structural,
exactly.
then there's got to be something other than
Right.
that. And if there are genetic variants within the chromosomal makeup, then it would be reasonable to assume it. There's just not enough research to prove it.
Exactly.
Okay. All right. Thank you.
Yeah, of course.
Hi, can you hear me?
Hello.
Hi, I have a quick question regarding the genetics, as she was talking about that.
Yeah.
So we did a genetics testing for our son about 3 years ago at the Mayo Clinic in Minnesota, and pretty much inconclusive. There's not really much that they gave us. So we were just still on track with our normal testing, all different types of medications and so on. Should I have my son retested, or can we still use the same, I don't know exactly how the genetics testing works.
That depends on what genetic test was done, for sure.
We had the microarray, and I think we had the whole comprehensive one, but I mean, this was 3 years ago. So I'm sure there's more research that was done, more things that have come up.
I would ask about whole exome sequencing. That's kind of here.
Okay.
There may be more genes that have been added to the comprehensive epilepsy panel, but at this point, if that's something that's available for you, I think that makes most sense. If the other panel has been negative, the challenge that we run into is unfortunately just coverage, right? Because many insurance companies won't cover these tests because
Nope.
Right, which is challenging. But sometimes we're able to do it if we write a letter or something. Sometimes insurance companies are a little more willing. Because I think that the thing that they think about is, well, you have this genetic abnormality, how is it going to change treatment and management? And sometimes it does, but sometimes it doesn't. But my argument always is, even though we know that most genetic abnormalities are not inherited, you sort of want to make sure that it hasn't been inherited and just not expressed, in a different way in a certain kid. So, but I would just, if you have the option to do the higher tier test, I would just do that if he's had the other ones done.
Yeah, because we're running out of options and we don't have any other drugs that we can use. We're kind of going back to some that have worked, but had some rashes, or, we're going to see if we could desensitize him to see if we could use them to control the seizures.
Yeah. Well, I will say I've had some success with after, if a kid has failed a medication a couple of years ago because, there was a side effect profile or something like that. I have had some success in the past with now when kids are a little bit older, trying it again at a lower dose to see if it's better tolerated. But
Okay.
when kids are not dealing with medicines, and each kid is different, but I do at least try to get information about the other options, ketogenic diet, vagal nerve stimulator, things like that. That's always my approach in general. So.
Okay, perfect. Thank you so much.
Thank you.
Can I ask a question?
Yeah. Hello.
So we're up in Seattle. We're followed at Seattle Children's Hospital, and my son was diagnosed at 3. He's 7 now. But you know, we had kind of a basic diagnosis. He was refractory, you know, failed 4 different medications. We've done all the genetic testing, the full meal deal, and come back with nothing, maybe one variant, but they don't know anything about it. So just recently I had him do an overnight EEG, and it came back that he was diagnosed. We got a first like actual diagnosis of ESES from that EEG. And so my question is, I've kind of brought this up with our doctors, but I'm just kind of curious to hear other people's opinions. Is that something sorry about that. Is that something that can change over time, or is it something that he's probably always had? Or do you see what I'm saying? Like, is it possible that epilepsy could change, or since we've never had the full overnight EEG, is it possible that he's had that since he was 3 years old and we just didn't know?
Yeah, it is hard to know. My sense is so ESES is a pretty, I don't know if classic is the right word, but it's one of those patterns where, you know, my sense is that it just doesn't magically appear kind of thing. Do you know what I mean? So it may very well be that he's had it for longer than you've been able to see it on the EEG. You know, just because, like I said, it's kind of a very significant pattern. It would be hard to say, all right, well, you know, he didn't have it a couple years ago, but he certainly has it now, especially if there's been no change in him, if that makes sense. Now, some kids can have a specific type of seizure at a younger age and then go on to develop ESES, depending on the type of seizure. So kids, believe it or not, who have certain subtypes of Rolandic seizures and Rolandic epilepsy can later on go on to develop ESES. But, you know, a lot of that has to do with the reason for it. You know, like sometimes kids have had a brain abnormality that causes ESES. And you can imagine that in that situation, it would be unlikely for it to suddenly appear. You know, but if someone does have one of these, like I said, an atypical Rolandic epilepsy or something like that, that is a form of seizure that can go on to develop ESES later on. But, you know, keep in mind, ESES in general is a pattern that we see. All it is very frequent spikes. So it's those spikes I showed, but they're generalized, coming from both sides of the brain at the same time. And the thing you have to be careful with ESES is that oftentimes it can be associated with things like regression. So kids lose language skills, they have worsening behavior, you know, things like that. So those are the things to, you know, be very careful with regards to that particular pattern.
So he's actually always been developmentally delayed, I would say. So that's kind of why we were thinking like, oh, I wonder if he's had this from very young and we just didn't know, because behavior has been hard for him, or not behavior, but learning has been very hard for him.
Yep.
So, you know, our neurologist or epileptologist actually said to us as well that she thought, you know, it could show autism behavior like things, just all kind of ADHD, all kinds of different things, which is all stuff that we've seen. And he's been, I've had him evaluated for autism and they said no. And I'm thinking, wow, so this is kind of, for us, it was kind of nice to get this diagnosis to kind of make a little bit more sense of everything. But, you know, she also said that most kids outgrow it. And I thought, well, how could he outgrow it? I mean, maybe he's not most kids, but that would be wonderful. But at the same time, I know that he's always had underlying seizures, you know, since he was, at least that we knew of, from 3. So I don't know that that's quite accurate, unless he's always had the ESES, and perhaps maybe, I don't know how truthful that is.
Yeah. No, I think, you know, in situations where kids sort of start out with some developmental delay, you know, it's often, those are the kids I worry that aren't going to necessarily grow out of some of these patterns. You know, I will say every kid is a little bit different, but my sense is the majority don't necessarily grow out of that pattern if they've started off as having some delays. You know, that's my sense. My typical approach is to see how things look over time, you know. So now that you have this pattern, it's good to take another look at some other point to see, you know, exactly how things are progressing.
Thank you.
Sure. And then I'll just add a couple things, sort of bringing up this idea of ADHD, autism, things like that. Keep in mind that when a kid is diagnosed with seizures and epilepsy, it does put them at higher risk for a lot of other things, like ADHD, like anxiety, like depression, things like that. So for me, what that means is that I just need to be extra vigilant about, learning and things like that. And I try to counsel families and just let them know that these are other things that are sometimes associated with kids with seizures and epilepsy. It doesn't necessarily mean that the seizures are causing those things. It's just whatever is putting them brain at risk for seizures and epilepsy puts them at risk for these other things as well. And I think that's super important because it's easy to forget once a kid has a diagnosis of seizures and epilepsy that there are other things that might be going on that we need to support them through. So it's just something else to keep in mind.
Hi, I have another question. Is an epileptologist somebody that our neurologist would refer us to, or somebody that we just decide like, oh, we want to see a specialist? I don't really know the difference.
Depends on where you live, depends on the resource. So a neurologist is trained in neurology, so seizures, headaches, multiple sclerosis, movement disorders, things like that. An epileptologist focuses just on epilepsy. My threshold to refer someone to an epileptologist is for sure if they're refractory to medications. So, if as a neurologist I've tried one or two medicines and they're not responding, that's my threshold to say, all right, you need to see an epileptologist. It's a little bit different because I am an epileptologist, so I can refer to myself, I guess. But that's my threshold for sure. If you're in a situation where the medicines aren't working, even if it's one medicine, I don't think it's ever wrong to say, do we need to talk to an epileptologist to see if they have a different take on things? Epileptologists are also specifically trained not only in managing very hard to control seizures, but also in reading EEGs. So I think we have a slightly better sense of how to correlate EEGs with certain syndromes, if that makes sense. So
Yeah, but if she's well controlled and everything's fine, there's no reason.
Yep. Correct. Yep.
Perfect. Thank you.
Hi there.
Hello.
Sorry, I put a question in the chat, but our son was diagnosed with epilepsy 2 months ago, and he's going to be 5 months this week. We don't know the cause. They didn't find anything structurally. The MRI came back normal, the genetic test as well. But we still haven't been able to control his seizures. If anything, there was a spike when they originally put him on Keppra, and there was a big increase. Like he was having 1 to 2, and then it went like 7 seizures a day.
Okay.
We've got to the point where he's no longer on Keppra. He's now on Topamate.
Dopamax, yep.
But we still haven't been able to control his seizures. He's having about 1 to 2 seizures a day. Like in your experience, I mean, how long do you think it takes to continue to kind of play with dosage and medications before we'll get to a point where we see 0 seizures?
Great question. So typically it can be several months for sure, because the challenge is, finding. So if a kid is not responding to one medication, that sometimes the challenge is finding a good combination. Sometimes, but yeah, for me, it can definitely take several months, because we always start at the lower range, and then, at least I always start at the lower range, and then build up to the more therapeutic dose. And sometimes that can take a little bit of time too. So that in combination with trying to find a combination of medications that works can delay things a bit. But again, it goes back to the choice of medicine, also goes back to the type of seizure. So if it's like one side of the body that you're noticing, there are other medicines that are just good for focal seizures. Some of those are Trileptol and lacosamide. Those are 2 medicines that I like for focal seizures.
He does have focal seizures.
Okay. So those might be a good option for him. And the other thing is, I will say this about MRIs that are normal in infants. So sometimes they can be falsely normal. So the brain doesn't really fully mature until like 2 years of age, somewhere around that time. So there have been situations where, we've repeated an MRI down the road and we've found an abnormality. It's just something just to sort of keep in the back of your mind. But how's the baby doing, generally speaking? If you're comfortable commenting on that.
So we saw the neurologist today, actually. So he says that cognitively, looks like he's doing well. I mean, he pays attention when someone's speaking to him. He follows you well with his eyes. But what we've noticed is that initially with his seizures before he was on medication, every time he had a seizure, we saw all the kind of the movement on his left side of his body would kind of shake a lot. And now that he's on medication, that stopped, but his right side of his body isn't developing as well as his left side. So every toy he grabs, it's going to be with his left-hand side.
Okay.
His torso is also a little asymmetrical because I don't think he's using his right side as much.
Yeah.
So we're going to try to get him into physical therapy.
Good idea. Yeah.
I mean, it's also so hard, because he's so young.
I know. Yeah.
I mean, I think overall he seems like a really happy baby, except, whenever he gets a seizure, but I also can't, he can't express how he feels.
Yeah.
It always happens right when he's either going down for a nap or waking up from a nap. But yeah, it's just hard to watch because he's so little.
I know. Yeah.
I mean, I'm sure for everyone, no matter what, your child.
Yeah.
Hi, Arnold. Do you mind if I ask a question?
Sure.
Cheers. My daughter has Javon syndrome, Jevons or Javon's, I'm not too sure how it's pronounced.
Yep.
So it's a new diagnosis from August. So with a lot of stuff on lockdown here in Ireland, so we don't, we can't get as much access to neurologists as we like, but she's had an EEG and photosensitive epilepsy has shown up in it. And she's had 3 tonic-clonic seizures, and she's been on the mobile phone in each instance. And so I've been doing a little bit of a deep dive on, I just started looking into photosensitivity and mobile devices. And I did an analysis of a few videos on TikTok through, there's a program called PEAT, P-E-A-T, from Trace, and what it does is it checks, it's a free version of what media companies would use to test video content for luminosity and for red light, things like that. So, man, it's like the Pokemon video, the results.
Yeah, right.
Yeah, pretty much like there's whole trends going through TikTok at the moment with a lot of transitions and a lot of flickering. Have you seen, like, is this something you've observed? You're nodding your head like it's something you're aware of.
Yeah, sure, for sure. That's well, I mean, I have definitely found that the cell phone in general can be a trigger, especially if you have photosensitive epilepsies, you can imagine. So that's not surprising. I didn't know TikTok and per se was associated with such high degree of flashing, but yeah,
particularly, yeah, it's because it's a lot around dance and movements, and the technology for amateur video production,
right? And
it's not equipped with automatic warnings. So it's not something particular anyway that you've come across.
Not that particular app per se, but definitely cell phone use in general can precipitate seizures and make them worse. So.
Okay. And would you recommend, should I get further EEGs to, like, will an eye patch work or blue glasses? Or
blue glasses. I would try blue glasses for sure. Yeah, because it can take out sometimes the frequency of light that precipitates things.
Okay.
So
good. Thanks very much.
Yeah, of course.
The advice is going straight to the walk-in patient. Thank you.
Thank you.
I have a quick follow-up question.
Sure.
So you mentioned Trileptol and Vimpat, that you kind of go to those. So we did Trileptol before, and we had our son developed a rash after a couple of weeks, but it did control his seizures. So this has been like maybe 4 years now. So if we tried this again, do you think that he wouldn't have the same kind of reaction? Because I mean, we did have some other drugs along with the Trileptol that we use. So we're not really sure because we're always on something.
Yeah, I mean, it depends on how bad was the rash. Was it
It was just on the inner thigh. That's about it. So, and we didn't want to, continue and see how far it would go. So we just kind of discontinued that, and then we chose a different drug. So I'm just wondering if maybe he wasn't old enough maybe for that drug, or.
I think if it worked, there's no downside to trying it. If you haven't done Vimpat or lacosamide, that's another. That medicine is somewhat similar to Trileptol.
We did Vimpat, but it didn't have any real effects. It kind of the same as it was before. But the Trileptol, I just remember that one worked so great, and it was just like that rash. So that's why we're going to an allergist to see if we could kind of desensitize him.
Yeah, no, I think if it worked well, there's no downside to trying it again, as long as obviously it wasn't like a very severe allergic reaction where you had a hard time breathing or something like that. But
no, it wasn't. So I'm just wondering if maybe it's meant for like a little bit older aged kid. Yeah. So
I would respond better to it now that he's a bit older. I think there's no downside in trying it again, especially now that you know what to look for with regards to the rash. So
yeah. Okay, perfect. Thank you.
Sure.
Could I ask a couple questions about your experience with ketogenic diet?
Of course.
I feel like a lot of the conversation that I've listened to yesterday and today has been really focused on the pharmaceuticals. And we've tried for non-responsive, no changes. And so we've started keto. We've been on a 4-to-1 ratio for about, middle of this month will be 4 months. I'm trying to put together my question. What kind of success have you seen with keto, with patients growing out, using that successfully and being able to grow out of needing the diet?
Yep. So number one, the ketogenic diet. So there are certain forms of epilepsy that are that the ketogenic diet is like the medication, if you want to say medication, the sort of treatment of this. So, if you're dealing with something like that, then that's kind of the way to go. I find that, the role of the diet outside of that is to overall decrease the number of seizures. So I found that for the majority of kids that I have on the diet seem to respond to it to some extent. Now, I must be honest, I've not been in a situation, unless I'm dealing with those other forms of seizures that respond very well to the diet, where I'm able to get them off all medications and just control them on diet. It tends to be the diet in addition to some medications, but with a little bit of help, a little bit of luck, less than usual. But a lot of it also has to do with, so the question of, can the diet lead us to seizure freedom and getting a kid out of a diagnosis of epilepsy? It sort of depends on what the underlying diagnosis is and what the course of that is. So, and also initial response. If a kid is responding really well to the diet in a few months, then I'm optimistic that we might get a kid to be seizure free just on the diet. So
okay. So if we've been on it 4 months, I mean, we had to commit to 6 months, which I totally understand.
Yeah.
But if we're not seeing results, let's say in 6 to 8 months, what's your general recourse to go to next? Do you continue keto? Do you try another medication? Do you just say, oh, sorry, we'll have to wait till you get more genetics details? Like, what are my next steps to anticipate for my child?
After 6 months, I tend to not, I don't think the diet makes any more sense if it's not been effective. At that point, I'll start thinking about different medicines that haven't been tried. And then again, depending on what the underlying reason is, sometimes I'll still go ahead and do just an evaluation for surgery, even though, I think an evaluation for surgery sometimes just makes sense because it gives you a better sense of, are there potential options out there aside from medication and diet? Are these less invasive options? Are they good ones for a certain kid, like the vagal nerve stimulator, or laser ablation, or other forms of surgery, like kids who have severe head drops, they can benefit from a surgery called a corpus callosotomy. So
Okay.
that's my typical approach. So for me, it's I try the meds. If they're not working, I'll say, hey, what do you guys think about the diet? Is it something you guys are able to do? Because it's hard, as you know, for anybody to do. And then if that's not effective, I'll go back and think, all right, what medications haven't I tried that I think could be successful? But at the same time, that's when I'll start thinking about just doing the evaluation for surgery. And that evaluation, it typically just entails coming into the hospital, capturing seizures. There are more sort of sophisticated imaging tests that we'll sometimes do. But that's my typical approach in general.
Okay, thank you.
Yeah.
Do you tend to have more follow-ups with EEGs after they're 2? You said the brain develops more fully once they're 2. I think all of our EEGs have been before my child was 2, and so
For me, it's more MRIs, because if there's been a negative MRI before the age of 2, and the seizures are focal for sure, then I'll oftentimes get another MRI, just a picture of the brain to see,
okay.
Just to make sure there's not some subtle abnormality. And the other thing is also the resolution of the MRI. Most centers do an MRI called the 3T, 3 Tesla. That's kind of one of the sort of the fancier / best resolution out there. So I would make sure that it's on that if it's something that's going to be repeated.
Thank you so much.
Yeah, of course.
Hi, I know you just said that you, in regards to the MRI, and I'm the one with the small baby. So our doctor said that if in 6 months from his first MRI, we are still dealing with seizures, that's when he would want to see another MRI or an EEG. What are your thoughts on that? Should we push for before, or is 6 months from his first one okay?
No, I think 6 months is okay.
Okay.
I think that's okay.
Okay, thanks.
Hi, I had a question in regards to my daughter was just diagnosed with juvenile myoclonic epilepsy. She's 17 years old, and her neurologist had recommended Keppra. We have a family member who it would be to her second cousin who had the same diagnosis around the same age. Her second cousin's now 22. So she had a lot of bad side effects with Keppra. My daughter had an episode in middle school, early high school, where she had a lot of bullying issues. So with some of the side effects with Keppra, I really didn't want to revisit that road, and I wanted to stray away from Keppra. And so we ended up starting Keppra. Well, she ended up having some side effects. She was starting to get really down, just wanted to sleep all the time. And so I had went back to the neurologist. This is 2 weeks after being on Keppra, and I had, presented him with all this information. And so he had said, let's put her on Lamictal. So I said, okay. So I said, well, what are we going to do with the Keppra? He's like, just completely take it away. I said, well, we don't want to taper it. I know she's only been on it for 2 weeks, but still just pulling medication away is just something I'm not for. I'm a med nurse for a psych hospital, so we normally taper off medication. So that's kind of how we do it. So I just thought it'd be better to taper her off. So we decided that day to taper her off by 500 milligrams just an hour of sleep. She was on 1,000 milligrams a day. So we started doing that. When we noticed that we started tapering her off, the last day she took the medication, we started noticing actually the next day she started having more episodes. And we've had this problem with her for, I would say, a good 1.5 years before being diagnosed. It was little myoclonic jerks, in her arm. She would hold a milkshake, she would drop it, and then she would like, did you see that, Mom? And I'm like, no, I didn't see it, babe. And then this was like, she'd have one episode, one every 3 months, just, it would be so spread out. So with that being said, after her being tapered off Keppra, she had 13 small to little seizures, I guess you can say. She was fully aware, fully, able to talk right away, came to, and then we do have a rescue medication. So my question would be, that day that she had 12 to 13 little episodes, would that be a good reason to give her that medication?
So it depends on which medication do you have?
Oh, good question. What is it? It's just a pill form.
Oh, yeah.
I'm trying to remember what it is. It's just, you just put it in the cheek and it dissolves.
Yeah. So the answer to that question has to do with what the typical sort of baseline is. It seems like 12 to 15 would be a lot in a day.
Yeah, that is most she's ever had in general.
Yeah.
So that was a lot for us. But like I said, she was still fully aware, but I was just thinking, well, I wonder if we should have gave it to her that day, because that's just so many.
Yeah, it seems like a lot. I mean, the little jerks fortunately aren't harmful to the brain itself, but if 15 is a lot in a day, then that would be an okay threshold to try. I think it's probably Klonopin what you have.
Yeah.
Something like that, as long as she tolerates it pretty well. The other worry is that you want to make sure that it's not a signal that things are going to ramp up and produce a larger seizure, like a generalized tonic-clonic seizure. So for that, in a kid who hasn't had that many in one day, I think it would have been very appropriate to give that medication.
Well, right now, my first suggestion when we had visited the neurologist on the 24th of September was, because I had done my research, and like I said, her second cousin has the same diagnosis. And I had, talked to her mom, and she had given me a list of all the medications that they've tried and what side effects. And I understand everybody's different medications, but I had really suggested Lamictal. I know it's like a mood stabilizer. I give it to some of my clients, and if it helps with seizures, less side effects. That was my whole goal. And he had just said, nope, let's do Keppra. So I said, okay, let's try it. Well, now he's having her start Lamictal while being on Keppra, I guess, to, keep her safe, because the maintenance dose of Lamictal, takes some time. So yeah, we're doing 25 milligrams for 7 days, and then we're going to just move up from there. So any thoughts on like maybe just CBD with the Lamictal, or should I just try Lamictal?
So with regards to, so with regards to juvenile myoclonic epilepsy and the medications that we know are the best for that, Lamictal is one of them.
Oh, good.
So you got to be a little careful with Lamictal, because one of the side effects of Lamictal, and this isn't a reason to not try it, is it can actually make the myoclonic seizures a little bit worse. Okay. So you got to be careful about that. But Lamictal, Keppra is a good medicine too. In boys, Depakote. But I don't use Depakote in girls, because the side effect profile is terrible, and it's just can cause neural tube defects in babies, things like that, for the older girls. So Depakote, Keppra, Lamictal, zonisamide, that's another one. And then I've had some success with clobazam, which is Onfi.
Okay.
I just hesitate with CBD just because there's no evidence to say that it could be helpful early on. So I think Lamictal is a good choice. The downside, as you say, is it's gonna take 6 weeks just to get to that starting dose. But
okay, yeah, and she's pretty tired all the time right now. Being on both medications, and like I said, with the Keppra, I just noticed she wasn't herself. She was really snappy.
Yeah.
Just really moody. So and it can also
sorry, go ahead.
It can also be, that she is a senior, they just pulled her license. I mean, that is a lot to process. I'm understanding that. So
if she's not on vitamin B6, I would try that too. That can sometimes offset the behavioral side effects of Keppra. And then that's harmless. So a little bit of vitamin B6 would be okay. And if that helps with some of the side effects while you're getting up on Lamictal and trying to get off Keppra, that would be good.
Yeah, I actually had mentioned that to the neurologist that day, and he's like, well, it hasn't she hasn't had any mood swings. We haven't started it yet. And I said, well, let's be proactive versus reactive,
Yeah.
you know, and I go, it's over the counter anyways. So, I mean, it shouldn't do any harm, but okay, perfect. Thank you so much.
Yeah, sure.
Can I ask you a follow-up question to the ESES epilepsy diagnosis I was talking about? So is the only treatment for that is medication? Is there any other treatments, and how do you find a good medication? Because I think the idea is to level those spikes, right?
Yeah, so the medication that I usually start with is some sort of a benzodiazepine. So typically I'll try clobazam. Classically, it's been high dose Valium has sort of been the medication. Other good spike suppressants, Depakote is one. I've had some success with Keppra. You know, if one of those doesn't work, you could think about trying the ketogenic diet, but I would try something like clobazam first if the goal is to suppress the spikes. I would start with that, and I usually give it at night, depending on how frequent the seizures are during the day, because the SES, as you know, is a pattern of sleep. So that's what I would start with for that.
Thank you.
Yeah, of course.
Thank you so much, Dr. Sansevere. We really appreciate it.
Yeah. Are there any other questions?
Thank you, Doctor, for being here.
Thank you so much, and thank you for the invitation. I really always enjoy this session, and yeah.
We
Thank you.
really appreciate it. Thank you.
Thank you so much.
Thank you for your time.
Oh, you're welcome.